Ministry of Health, and other partners. And in Uganda, we have 3 independent HIV clinics, one of which is Charles Farthing, where our head offices are in Kamocha, another one downtown, St. Valley Kudembe. We have another one in Lukaya, those who take that road to Masaka. And then we have another one in the Masaka Regional Referral Hospital as an independent HIV clinic. And all of those independent clinics are high volume clinics. So we have got an opportunity as an organization to interact with young people, both those who are living with HIV and those who are positive. And part of our program is the Young People's Program, which looks at ages of 15 to 24, but we also have an independent specific program that targets young girls between the age of 15 to 24. And these programs are meant to provide or address issues of primary prevention of HIV. They help us enroll young people in care, but also keep those who are positive through different approaches, providing information, advocacy around comprehensive sexuality education. And over time, we have been able through those programs to maintain our young people in care. Adherence has improved, and they are living, in good health. So with that background, I think I now justify why I'm standing here to moderate the session. So we have 4 abstracts. I'm yet to confirm the 4th person called Kobsinje. Kobsinje, are you around? Okay, Kobsinje is not around. So which means we have 3 abstracts that we are going to look at, and the presenters are ready. And the conversation is HIV and sexual reproductive health. I'm not sure if every one of us has been able to look at the recent HIV Global Update report, and also the recent HIV report that was released, I think this week. Those of you who are on the RMNCH, CSO, and Young People's Group, there is a current report with latest statistics on HIV, and it also highlights statistics among young people. So maybe to bring people up to speed about the current statistics on HIV, globally, from the recent UNAIDS report, we have over 39.9 million people living with HIV globally. And the sad bit of it is that 9.3 million are not receiving HIV treatment. Yeah? But remember that we have a global commitment that we made. When our leaders met, they had a global commitment that they made that they should end HIV by 2030 as a public health threat. However, when you look at the current statistics, in certain regions in Africa, we may have dropped in terms of prevalence, like the sub-Saharan Africa, but still the statistics are high in certain demographies, especially around young people, and when you talk about young people, more in adolescent girls. So, of course, that puts us at stake, and now the emphasis has been put to ensuring that we reduce HIV infections among young people, with a focus on both boys and girls. And when we look at the statistics recently that they released yesterday, in Uganda, we still stand at 1.4 million people living with HIV. And the prevalence among 15 to 24, among the males are over 40,000. And then the females, we have 110. That tells you what is happening among the girls. Then when it comes, and that is between 15 to 24. When it comes to 10 to 19, new infections per week, we have over 730 new infections per week. And out of that percentage, a lot of it is geared towards young people, especially the girls. So with those statistics, there are people who have put up abstracts to share with us knowledge on what has worked or what could work to respond to the high infections of HIV among young people. So I'm going to invite our speakers today up here to tell us through their abstracts what they have for us, because this is a knowledge sharing session. So we ought to learn from one another, and we have 3 abstracts on table. So I would like to invite Hope Divine to take up the stage, and you'll still be our first presenter, but I would like all of you people to come up. Then we have Lodrick Wabwire, and then we have Samuel Katamba. So as you take the stage, let us be mindful of time. Every one of us is going to use 10 minutes, that is presenting. So make sure within those 10 minutes you're able to deliver. Where you think people are aware of the statistics, please run through. Yeah, so, okay, you corrected me, Samuel Katumba. Okay, so you almost remained back. You will miss heaven. You will miss heaven. Yes, so we have our people who are going to present to us. And most importantly, let us give them the attention. Remember, it is a learning session, knowledge exchange. And on that note, I want to first confirm with our machines, our DJs, people who are in the... Are you ready? So we are starting with Hope Divine. So let her presentation be up. Okay, fine. Okay. Okay. They are making the time like tighter. So if the presenters can even reduce from 10 to around 7 minutes, so that we also allow to have plenary, it will be very good. So I want to invite Hope Divine to take us through your abstracts. Thank you, and you're welcome.
Oh, yeah, thank you. Thank you very much. Once again called Mugide Divine Hope, representing Bale Network of Young People Living with HIV. I'm pleased that I wrote an abstract which went through, and I'll go straight to the details of my abstract. So okay, so my title was Pioneering Gender-Sensitive SRHR Interventions for Youth, a Holistic Approach. Go to the next, okay, let me just give you a brief, first take me to the first slide. So, pioneering gender-sensitive SRHR interventions for youth. As I had clearly stated, I come from a youth-led organization, that is Mbale Network of Young People Living with HIV. And one of our focus areas, rather thematic areas, are SRHR and HIV. So, with that, I'll go to the next slide. So, definitely, those are my names. Next slide. So the title of my abstract was Enhancing Access to Comprehensive SRHR and Reproductive Health and Rights, Education and Services in Bale District. I'm pleased to let you know that last year, around November, we got funding from PTY, that is specifically RHU, that came through and supported us. And our main focus was looking at enhancing access to comprehensive sexual and reproductive health rights and education and services in Bale District. We were using the whole school approach. So kindly go to the next slide. So the issue we're trying to address was the inadequate access to SRHR education and services for young adolescents in schools leads to high rates of teenage pregnancy of learners. So in this scenario, still back to the other slide. In this scenario, we implemented a whole school approach, and we did visit 4 schools, that is 2 primary and 2 secondary. And the main issue was getting to help the learners understand what information is detailed around sexual reproductive health and rights. And in this, we used to, as we were visiting the schools, we had post-evaluation and pre-evaluation tests where we assessed the knowledge of the learners, these young adolescents in schools. So kindly go to the next slide. So, so there you see that those are some of the evidences, the action photos, where you can clearly see. Sorry, the other slide. We're moving fast. Okay. So there you would clearly see we are integrating comprehensive SRHR education in schools. So we are addressing teenage pregnancy and gender inequality in Wanale and Jawa sub-counties. Those are sub-counties from Bale district. So we invited our PTY focal person from Bale district who used to help us while carrying out these sessions, because we believe that partnering and connecting is very good. That's hence inviting him to most of our sessions where we used to have learners in class. Of course, we started small. Those were about 50 learners per session, where we would have knowledge sharing, evaluate how much they know about SRHR and HIV. So next slide. So I'm giving a brief background. Bale Network of Young People Living with HIV is a youth-led civil society organization in Bale City. We are found in Bale City, but most of our intervention goes to the district bit of it. So we mostly go to the hard-to-reach areas. We recognize these challenges and sought to address them through a project funded by the PTY Small Grants. The project aimed to integrate SRHR education, improve health service access, and provide gender equality among young people in schools across Mbale district. So the next slide. So as I had earlier on said, we used the whole school approach, and while using this whole school approach, we basically implemented 2 activities. That was the monthly SRHR/GBV safe space dialogues and the inter-school dialogues and advocacy. So we can go to the next slide. I can go give you a clear picture of what we meant about our monthly SRHR and GBV safe space dialogues. So these safe space dialogues detailed a lot of information sharing and giving, where we sat with the learners, assessed how much they know, because remember, these are learners from hard-to-reach places, and I must say, we were pleased that, of course, these young learners, as much as they come from the less privileged areas where information sharing is limited and there is a lot of access to digital information, or maybe they may be getting it, but then there was a lot of myths and misconceptions when you hear learners telling you that actually, for them, they know that using salt can help lead to a safe abortion. It's very absurd. So when we used to hear such information, while we gave them these pre-evaluation tests, we realized there was a lot of misconceptions surrounding what they understood about sexual reproductive health. And mind you, that while interacting with these learners, we strictly followed age-appropriate information, where I know learners from the category of 10 to 11 may not access the same information as learners who are 18 years and above of age. That's why I said we used the 2 secondary schools and 2 primary schools. Some of what we used to do under the comprehensive education was tailored SRHR education programs. and we had empowering young people with knowledge about SRHR. So this was more of what was detailed in the monthly SRHR stroke GBV safe space dialogues in schools. So kindly go to the next slide. So our second intervention being the inter-school dialogues and advocacy, where we invited multi-sectoral stakeholders. This meant we invited a lot of categories of people in their respective positions. So we invited cultural leaders, political leaders from political affiliations, and we invited parents, of course, and the young people themselves. Because while we interacted with these young people, we made it a point of reference that they should be able to identify the issues, them as young people, what are those issues affecting them from actually getting access to SRHR information. What are those issues? So in the inter-school dialogue, it was basically them presenting their issues to the stakeholders so that we would draw at the end of the day an action plan where we had to do more of advocacy, of course, because we are advocating for the rights of the learners while in school. So here we're engaging high-level stakeholders. Okay, young people presenting issues to challenge gender inequality. Next slide. I will be a little bit fast, my time. So looking back at the time when we implemented this particular programs at school, we realized there was increased access and knowledge about SRHR among the young people. There were a lot of misconceptions which were demystified. And yes, the young learners were able to come out and actually appreciate some of the knowledge sharing sessions. Then there was improved knowledge sharing through the sex education talks at schools with learners by the senior men and senior male teachers. A point of reference was in one of our primary schools, we realized there is no time allocated for these talks with the young learners. So henceforth, there was a lot of high teenage pregnancy in this particular school. So we realized there was need to re-empower these senior women and senior men teachers to understand their roles in the lives of these young learners. So capacity building of CSOs like MONIPA, that is our short abbreviation of our organization, for sustainability, community impact. As a matter of fact, would love to really appreciate PTY, specifically RHU, for the much support they provided for us, because there was a lot that we did, a lot of capacity building. For instance, there was a lot of capacity building in the sides of financial management. We understood that anyone who is not a non-financial person can actually sit down and make a requisition, what details of a requisition, what details of a payment voucher and all. So due to time factors, let me kindly hurry up, please. I think this is my second last slide. Next slide. Okay, 2 minutes. So clearly that is just a table detailing the numbers that we reached out to. In our safe space dialogues, we had about 241 females reached, and 241 females reached, and with the males, that was around, that particular figure, 116. So you would go to the graph. Still, this graph is showing you just a reflection of these figures on the table, and then you go to the next slide. The next slide. So some of the lessons, the key takeaways. So some of our key takeaways was there is need for structured information flow, a structured system in place to ensure that important information is constantly shared with students, not only about menstrual hygiene, but others. Could you make it a little bit wide? Yes, but other SRHR information. And following our presenters earlier on, the commissioner from the Ministry of Gender, he clearly spoke about how they are looking at ensuring that there is structured information that is going to come at the end of the year that is going to help guide our sexual reproductive health and right talks in schools, not only just for us, but also for the senior women teachers and male teachers in schools. So the next key takeaway, was myths and misconceptions about safe abortions. As I had told you, you'd find it absurd when a young girl comes to you and tells you, oh, you know what? I know that when I take a lot of salt into my body and I have conceived, I can actually abort, and it's successful. So the last being, there's a lot of parental negligence where young adolescent girls are left at the mercy of these young adolescent boys to keep facilitating their educational needs, leading to sexual relationships at a tender age. Those were some of our key takeaways while implementing the whole school approach. Thank you.
Thank you so much. Let us clap for... Thank you so much, Hope. Thank you for sharing with us. That was a beautiful presentation and abstract. Of course, you were sharing with us in regards to access to comprehensive sexuality education. I'm yet to hear from the audience. You know, some of the questions that come through, you kept on mentioning SRHR. We would have loved to hear what exactly is within the SRHR package. How did you access information? You talked about information flow. But we wanted to find out how did you get access to accurate information that you shared in the schools. We wanted to learn how was the school cooperative for you to share that. But we also acknowledge the elements you have mentioned that we need more platforms in school to have that conversation. We need more information. We need to, of course, the myths and misconception already reflect that there is an information gap on sexual reproductive health. So we take note of those, and I hope the rapporteur is actually taking notes. I don't know who is the rapporteur of the session, but the number of things that are coming up in this session, and thank you so much, Hope. So I would like to have our second speaker, who is Lodrick Wabwire, to take us through his abstract or presentation. Thank you.
Thank you so much, our moderator. My name is Lodrick Wawirodo, and I'm from Makere University, Department of Population Studies. Okay, thank you. We did this study in May last year. However, we first did the mapping in December 2022. So my title is Sexual Behaviors and Experience of Young People with Physical Disabilities in Accessing Sexual and Reproductive Health Information and Services in Chotra Border district or area. This paper that I'm presenting, we already submitted it for publishing, and we did all the comments. So we're just waiting for the final remarks. As we know, young people with disabilities often have a lot of challenges as compared to these able-bodied young people. For the case of Chotra district, we selected because being the border dynamics and Kasensro as well. Those of you who know Kasensro, it's borders TZ and Uganda by the lake. That's Lake Victoria. So we know that young people with disabilities in Uganda, not only Uganda but elsewhere, have a lot of challenges that they face while accessing sexual and reproductive health services and information. We, based on the 2014 census report, we've just done the census, so based on the previous one, and we realized that around 12-24% of the population we had some form of disability, of which 6.5% had difficulties in seeing. And please, can you go to the next slide? Thank you. The next one. Okay. Yeah, so we also saw that 5.4% of the population by then had difficulties in remembering. That's issues with memory. And those ones who had difficulties in walking were 4.5%, and difficulties in hearing were 3.1%. So therefore, because of that, we set off to Mutukula to assess the following. One, we wanted to find out what are the sexual behaviors of these young people with disabilities when it comes to assessing sexual reproductive health information and services. And secondly, we wanted to find out what are their experiences, what do they go through when they try to access this sexual reproductive health information and services. Therefore, this was purely a qualitative study, and we selected Mutukula Town Council and Kasese Town Council. They are under Chotera District, and this was done purposively, based on the border dynamics, that one of the lake, and the cross-border trade, the truck drivers around the Mutukula border. Our sample size, we wanted the sample population, we basically based on young people 10 to 24 years, and a household could only be eligible when it had a young person who had any physical form of disability. Why physical? We really wanted someone who can talk on their behalf. Because sometimes when I meet a mom, because the child can't talk, the mom can tell us something that's not real. So that's why we wanted those young people with disabilities who can say something on their own behalf. We got the ethical approval before we conducted this study. We got the ethical approval from the Task Force Research and Ethics Committee. Next slide, please. And we also went ahead to forward it to the Ugandan National Council of Science and Technology. When we went to the field, our ethics didn't end there when we approved to the National Council. We also sought permission to conduct the study from the district headquarters and also at the local council plus the individuals themselves, because it was voluntary. We couldn't force anyone to participate. Next slide. Next. Next. Thank you. So we went to two places, that is Kasensero Town Council and Mutukula Town Council. And you realize that most or majority of our young people, we got them from Mutukula, not Kasensero, and that was around 66.7%. This was because when we went to Mutukula, we realized that in Mutukula, once a young child, especially the girl child, when they raise the age of 14, 15, their parents tend to take them further away from the area because it's a fishing community. So they take them away to the relatives to help them not acquire those diseases, HIV. I hope we all know what happens at the landing site. So they try to save them from that. Our age group, majority of them were aged between 10 to 14 years. And we had the physical disability form, around 58.3% had mobility impairment. Those ones who had issues with walking or moving. And gender, we had most of them, that is 67%, who were males. Then we didn't stop there. We also assess their marital status and realized that 83%, that's close to 3/4, 83% were single, not married. And for religion, most of them, that's 58.3%, were Catholics. And for education level, most of them had primary education, that's 83%. The occupation-wise, we realized that that's a majority, at 58.3%, were students. And only 16.7% were doing fishing-related activity. Now, we did not only interview these young people with disability, we also talked to the key informants. The key informants we talked to, those are the people who oftenly work with these people, those ones were their parents, and we had health workers. So the first one for our key informants, most of them were also Catholics. Then the education level for our key informants, they had a certificate, that's 4.42, close to 43%. And for the gender, most of them were males, 71%. And the occupation, they were health workers, because we wanted those ones who have good knowledge about these young people with disability, because they're the ones who treat them. So we we assessed the sexual behaviors. And like I said, this was purely qualitative study. After collecting the data, after transcribing, we generated our codes and wanted to find out. Please, can you go to the next slide? Next slide. Next. Yeah, so we assessed and we wanted to find out what are the sexual behaviors of these young people with disability. And we realized that the majority of them were having unsafe sexual practices. What do we mean by this? We went further to ask why is this happening, things happening the way they are here. And we realized that those people, the young people with disability, they were not using condoms when they go for sexual intercourse. And to prove that, it was justified when we went, we found 4 of them had pregnancies. 4 of the young people, 4 of them had pregnancy. Then we saw another thing that those young people, especially the girl child aged between 15 years and above, they had multiple sexual partners. Next slide. Most of them had multiple sexual partners, and this was surprising to some people who thought these young people with disabilities are being ignored by men, and this was surprising. So we went ahead to find out what are the experiences for these young people with disabilities. What do they go through? One, we found that there was a lot of sexual violence. The rape cases at the border was a lot. We remember the border dynamics that I talked about in the beginning. We have, Mutukula has a lot of, like so many communities from different countries. Being at the border, have people from TZ, Uganda here, then Rwanda and other areas. So they had a lot of rape cases, and we wanted to find out who are these people that rape these young people with disabilities, and we didn't get a good answer because many people told us they're not certain because they don't see them. Then the other thing that came out was transaction sex. Being a border setting, we realized that these young people with disabilities engage themselves in transaction sex. And we went deeper to find out why, and they told us Mutukula as a border has so many bars at night. So these young people with disabilities, when they go there, they are easily deceived. They are easily lied to. A man goes to them and they easily give in. So we also experienced that these young people have a lot of transaction sex at the border. And the other final experience that we had was long distances to the health facility. We also observed it ourselves that when you go to Mutukula and Kasensero, the health facilities, they are mainly at the town areas that are the centers. So the town, because we interviewed people in the town council, so when you go to further places, those ones who had mobility issues, they were finding it hard to access the health facilities. And this was a serious challenge for them. They told us most of them use borders, and you know if you have a health complication and you're going on a border, instead of solving what you wanted, you end up having more issues. So those are the experience that we got. So we had some lessons that we observed. Can you go next? Thank you. We realized that most of these young people, most of these places in the hospitals, they don't have focal people. What do I mean by the focal people? They don't have someone who is in charge of the people with disabilities. They don't have that person. And when these young people with disabilities go there, they find it challenging to access the services because, one, they find it hard to meet some people because they fear. They have low self-esteem. Then the other thing was, even in schools, and some of this came up when we went for the dissemination, even in schools, the teachers call these young people with disabilities abalema in Luganda. So it's to them, it's like it's abusive. They don't feel okay when they meet other able-bodied young people. So that was also something that we observed both during the data collection and during the dissemination time. Then the other thing was there was limited awareness about how these young people with disabilities should be handled, even at home. Because we went further, we published we had 2 papers out of this, And the limited awareness part, we realized that most of these young people, they don't stay with their parents. They stay with non-biological parents, which becomes very hard for them to discuss SRH issues. And also they ignore them saying, even if I educate this young child, those ones with disability, where are they going to get jobs? So they ignore that. And the other thing that we saw, we realized that these young people with disabilities are not empowered, both economically and academically. So that was one of the reasons why they were engaging in transaction sex, because they don't have finances. Most of them come from humble families, and that was so challenging for them. The other thing that we saw that they are lacking guidance and counseling services. And that was serious to these young people with disability. They don't know when, by mistake, when I get a pregnancy, what do I do next? Or before, when I'm going to have sex, what do I do next? Should I use a condom or not? So those are the key things that we found out. Next slide. And therefore, with those few remarks, I would love to acknowledge the Carnegie Corporation of New York. They're the ones who funded our study, and all the stakeholders, including NUDIPU, because before we went for the data collection, the reception meeting, we met NUDIPU guys, and they helped us to develop the tool. So we worked together with them, and also all the study participants, not forgetting the field guides and the research team. I think that was me. Thank you so much for your attention.
Wow, thank you so much for this wonderful presentation. It's giving us good findings, very unique, targeting one of the most key groups that actually in most cases are ignored. And we take note of the recommendations, but also the highlights that you share with us. One of the most interesting, not interesting, but one of the things I think that we need to kind of look at, having multiple sex partners, engaging in commercial sex. The question is it safer sex? That's the question. But then you also go on to mention that they have limited access to health facilities. They don't have a representative in their districts who be in charge of disability-related issues among young people. So these are issues that they are bringing on board, not just to listen. We need to integrate them in our programs. We need to advocate in the districts where we operate to have all these things addressed. So thank you so much. It was interesting. I hope this can be disseminated for action at different levels. So I want to invite our last presenter, Samuel Katumba, right? Yes, to take his presentation. And then we shall go into a short plenary, and we shall call it a good session. Thank you.
Thank you so much, Diana. Good evening, members. I welcome you once again. I'm Katumba Samuel from SDI. SDI is Sustainable Development Initiatives. We are based at Kalangala in the fishing communities. So it is good in the house. Also, I have the team. We work in partnership. Till last time, I will introduce them. Our advocacy issue was looking at the two populations. That is the adolescent girls and then the younger women. So the issue was to reduce unintended pregnancies among adolescent girls and the younger women in the Kalangala district. Why the two populations? Much as we are putting much focus on the youth, but even there are younger women who get pregnancy, but they don't want the pregnancy. That's where even at homes we have the GBV coming from. You find people fighting because one partner was not in the mood to get pregnant. So my research was looking at the two audiences. The background, just looking at what is SDI. SDI is a CBO based in the fishing communities in the middle of the Lake of Victoria. But we are focusing on innovative approaches in health, livelihood, because we can't go away with the livelihood. We need to bring it on board. sexual reproductive health rights, mental health, and climate change. Later, I will explain why we need to integrate the two. So our values, also we believe in partnerships. You remember the previous presenters, we are talking about strengthening what? Partnerships. So we strengthen partnerships. So our mission is we are committed in delivering innovative health approaches. So our target population in this research was 13 to 19 years. Then adolescents 10 to 19 years. So you see just like 15 to 35 years. And then also we have the adolescent younger women, 15 and 24. So as you know, projects are based on statistics. We had the statistical background. We looked at the UNFPA report 2022, where they said that 15 to 19 girls have had a child or are pregnant. Then 34% of Ugandan girls were married by 18 years. Then 28% of the maternal deaths occurs among younger girls, 15 to 25 years. Then younger people, that bracket, they are also responsible for HIV. Remember, Diana was sharing to us the current statistical figures. So it is out of that figure, 34% of the new HIV infections were found among the younger girls. So still, we are saying that the challenges that Uganda still faces some societal governance and physical barriers in accomplishment and the protection of SRHR. We are saying that achieving SRHR, be it decide when and whether to have children, is essential for the health and well-being of all women. Yet, recent data indicates serious gaps in SRHR in Uganda. So they quote the figure that an estimated of 649,000 women aged 15 to 19 are sexually active and do not want a child in the next 2 years. However, among us, this group, more than 55% have unmet need for modern contraception, meaning that they either do not use a contraceptive method or use traditional method of contraception. Moreover, many adolescent women who give birth each year do not receive the vital components of maternal and newborn care. So the barriers we looked at the barriers that we have: the governance issue, we have the restrictive policies. Remember, recently the law was passed about on anti-homosexual. So all of those ones, there's corruption, inability to uphold the laws and the citizens and the societal barriers, the gender norms and the values. So you find that we have our honorables. They are the ones now on the side of policies. For example, when they are passing out these laws, they just look at one side of the coin, but not looking at the other side of the what? Of the coin. So this puts HR issues at a challenge. So we call upon the politicians such that when you are passing out these laws, you also look on the other side of the coin. Because as much as we are talking here SRHR issues, unless there's a mindset change of the politician on this issue, we are still further we asked if the amendments of other laws, why is it that when it comes to SRHR issues, there is no amendment? We would love to hear in the fishing communities if tomorrow there's an honorable tabling an amendment on the law that was passed, such that also we can look out to the other side of the what? Of the coin. Thank you. As another slide, go ahead. Quick. So you look at those are some of the photos trying to show the programmatic work we are doing, engaging the stakeholders at different levels, but more so bringing the vulnerable children at the center of the project. So such that they can also pass out to the what? This information to the fisher folks. We looked at the conventions that was passed out, where even Uganda is a part of those conventions. We looked at the ICPD, that looked at the SDG number 3 and number 4, And then number 5, the SDG number 3 was basically looking at the good health and well-being, whereby ensures healthy lives and promote well-being for all at all ages. The goal number 4 was ensure inclusive and equitable equality education and promote lifelong learning opportunities for all. The goal number 5 was looking at the gender equality and empowerment, empower all women and girls. So those are the way. You got another slide? So our approach, those are showing the approaches we use. We do community mobilization. Then from there, we do the sensitization. Then the sensitization also we do some part of the service delivery, whereby these younger girls are given, apart from this information, also they are given the services like the counseling services, the STI screening, and the testing services. Then the other side, whereby we do advocacy, we bring the stakeholders, the decision makers, where we have the sub-county, councils, LC1, LC2 on board. So those are pictures, they show different areas. Yeah, so we had the objectives, those are what we call the pathways. One was to empower, to create space for the younger girls and the younger women to have voice. Then 2 was looking at the CSO's capacity in such that we can deliver quality information. Then number 3 was looking at the decision makers to have the information and take an action. So some of the activities was to do the community mobilization, then the sensitization. We had to do the community outreaches of the SRHR issues that included the family planning and what have you. Then we had also to engage the women, the younger girls and the women through the meaningful engagement, that is using the sports activity, as you see those photos. So in the sports also we integrate SRHR information and the services. Yeah. DJ, understand? So those are some of the results we reached to. So there's what we call smart advocacy. Smart advocacy, that's where now we engage the decision makers, we come on board, we talk on the issues. Our issue was teenage pregnancy. So we looked at those barriers, why there's still a challenge in Kalangala. So at the top there was some figures, whereby in Kalangala we were at 42, 37, then after 5 years it was increased to 42%. So you can see the number was increasing. So those are the numbers showing different age brackets of the people we reached to. And then the SBCC, social behavior change, that's where now we have the music, the drama, bringing all other Fisher Foxy on board. Like the role play you saw that at the beginning, the picture. So that is the social behavior change, communication, and advocacy. Meaningful engagement, that is the sports we are talking of. So those are the numbers. Yes. So lessons learned during the interventions. Also we had to see how we can do the advocacy in another way. We said number 1 that we need to engage socio-economic empowerment programs that come in the community. That is like the parish development model, then the Myoga. So we integrate these empowerment programs within SRHR to reduce on the drivers of teenage pregnancy. Because we found that some of the drivers is low household incomes. That's why the Fisher Foxy influence these younger girls. That's why these women, they get pregnancy, unwanted pregnancy. So we say, if they can be empowered economically, using the government program that has come to the community, then it will be a step ahead. Also, we are saying that also integrating mental health. Mental health, you find that now these guys, they deliver at teenage age. So that trauma they go through, they need counseling. In the morning, we had my colleague from Buko was giving us an experience she went through. And you see, she had that trauma psychologically. So they need intensive counseling. Vis-a-vis also, there's drug use, alcohol in the fishing community. So these guys also need to do what? To do counseling. We said that also we need to integrate the mental health. And then also we need to integrate climate change. Climate change is now a key, is a threat to progress in SRHR. Here there's a research from UNICEF. They say that it is impacting every aspect of child health and well-being from pregnancy to adolescence. So they further say that climate-related hazards will lead to an increase in pregnancy complications and adverse birth outcomes, malnutrition, infectious diseases, injuries, non-communicable diseases, and the impact on neurodevelopment, mental health, and well-being. So climate change, I'm sure even you in Kampala decide there's one day when you expect much heat, whereby it even goes up to 40%, 40 degrees Celsius. In Kalangala, we have months from June, July, we experience strong turbulent winds on water. Now imagine that period, a lady in a certain island, they need contraceptives, but the health workers can't go there. What will happen? You end up getting pregnancy. So climate change is very, very pertinent. If you are to draw a graph here, this side on horizontal having temperatures, vertical having the years. In 1980, the UNICEF said that it was the percentage, the degrees were at 0. 2022 now, the degrees it is 0.89 Celsius, which is very, very high. So when it comes to regions, also it differs. So we need, those are some of the lessons learned, but still we need to do acknowledgements of power to use at the consortium. Then the Kalanga District local government for giving us the space. It's good the deputy speaker is here. We have the district focal person of power to use, the structures, then the sub-county local government, where we have the LC3, LC2, LC1, then we have the health facility, which we are partnering with, then the primary school, which was doing the role plays, the Weke Primary School, and then the fishing community. Still also thank the DCDO, that is the District Commercial Officer, where we report, we give out the reports we are doing. And then there's also the structure, the CDO, and the team at the ground. Also, I thank the member organizations from Kalangala. We have Kadingo, represented by Madamu Idi Takaros. We have the district speaker. We have the Bida Silive. Then we have other players, the Kafofano and HIV. So they are there. So we are not doing this work alone. Also, we are in a partnership with those people. So I take this opportunity to thank our members. Thank you so much for listening to me.
Thank you so much, Mr. Katumba Samuel. That was an interesting presentation around adolescent girls and young women, focusing on teenage pregnancies. I like the statistics that you highlighted across the different age brackets, and they are very interesting. Of course, these statistics have been highlighted in the different statistics and research, like the UDHS, the recent one. And so this presentation that you're making just emphasizes the areas that we need to look at and consider. I like the aspect of integrating entrepreneurship or skills, life skills into SRHR. I think it is one of the things that you've highlighted, something to take up. I know we could be doing certain interventions, but this re-emphasized that we need to scale it up among the adolescents and young women. I like the highlights you have given and linked to the commitments we have made in ICPD, SDGs. This, of course, holds us accountable as stakeholders on how far we have gone in implementation around these commitments. And you also went ahead to highlight some of the barriers, including low uptake and implementation of SRHR policies. You spoke about the AHA policy. You mentioned about issues of social barriers, corruption, like all this impinge like implementation of SRHR programs and interventions. And I would now like to hear, of course, there's things that you have also highlighted as lessons, some of which you mentioned that if we do smart advocacy, we can be able to create some change. You also mentioned about behavior change, communication, how we communicate to young people, especially the adolescent girls and women. You also highlighted challenges like high levels of drug abuse, and so leading to the current high levels of mental health among young people, but also you highlighted issues of climate change. It may not be different from what you know, but this further gives us a picture of what is happening. You could be operating in Lira, he could be operating in other districts, and you see the situation is either worsening or the same. So this further, helps us to bring together the effort, the resources, the planning, together to do advocacy and programs and initiatives that respond to these issues. Thank you so much to our presenters. I want to open up this conversation to the congregation, and I want to start with the first hand up. The presenters are ready, and I hope we still remember the different presentations that were made. So I'll start with you. Do we have a microphone, or we still need to use this same one? Do we have a microphone? We are taking around 5 questions, and then we will close the session. It's not a lot because we don't see people inside here. They can actually come in and join the conversation as we wrap it up. So you can give him to ask his question.
Thank you so much. My name is Praesh Jumba. I work with Topoa Center in Uganda. We implement programs around the youth. Number one is divine. Thank you so much for that abstract and the implementation. My questions would go to the discrepancy in female engagement versus the male engagement. I see a figure of 241 versus 116 males, 241 females versus, that's about our difference of 125, and yet these are people that are going to stay with our girls. It's upon us now as CSOs to really up our game in programming to make sure we are being as inclusive as possible. So much to say about the myths and misconceptions and parenting.
What's the question?
The question on, the first question was that discrepancy.
Yes.
And how does that affect our programming? How, was it intentional, or it was just because the males were not able to really attend to the program as you really wished?
Noted. The second one?
The second one, I'll go to the second panelist from the study by the Population Studies School. I see you report 10 to 14 years at 41%, 41.7% participation by this age group and 33.3%. Now I get to the questions versus the age group, and I get to ask at the back of my mind, if we are talking about condom use, what is the feedback from the field? Ideally, I'm basing this on the study report. If your highest number of participation of participants was 10 to 14 years, and we are reporting transactional sex, condom use, what do we need to do that hasn't been done to make sure we change the status quo? Or is it because, or we might have to have the breakdown of the question response tailored to the age groups so that we can understand where the problem is?
Okay, those are.
I think for me those are my questions, and thank you so much.
So thank you so much. Yes, please, sir. That's the second question. Who are the people? Okay.
Thank you.
Third one, the gentleman there, and okay.
For recording purposes, I'm Okumu Sem, District Community Development Officer, Busia District. I have only two issues. One, I want to commend the abstract from Makerere University. It really touched a very...
Let's be quick because people are coming in. We need to conclude
Yeah.
on this. Yeah.
It touched a very rare category of people that we are looking out for information for programming. However, when you were presenting, you were quoting a lot of responses. A lot of these were responding. It is a bit hard for us when we are programming to use such information a lot. It needs maybe to be quantified, perhaps basing on your respondents. Two, on the first panelist about whole school approach. I'm just asking, were there some responses concerning stigma on the young children, the children in school, and also were there some issues to do with the non-suppression because of lack of meals at school and lack of adherence because of lack of meals at school when it comes to HIV/AIDS and infections and in the schools? Thank you.
Thank you so much. That's a very good question on point. Yes, sir.
Thank you very much. I'm Moses Lubanga.
I hope we are taking note of our questions. Yes, please.
My first question goes to our first panelist. We have seen the response from the students. Before we go any further, or we go for another survey, how was the response from the parents? Because we saw you interacted with the parents or the stakeholders. What was the response? Because it was vital for us to be given that response so that we can again go to what? Another survey. Then the other survey, Ms. Awawire, you talked about the response from these people, the disabilities, but they have political representatives. Do they get a chance to interact with them? If not, what was their response? And how was the response from the parents you surveyed? Because parents tend to ignore or tend to be conscious with the information they give out. I beg you to submit.
Thank you. Yeah. That should be the second last because we have a hand here.
Thank you, Diana. I had two questions for each of every presenter, but I will do one for the first two.
Thank you.
The first question is what you built on. She mentions of unstructured information, which is in the current state. So I would love to know what kind of information did you provide if there is unstructured information. Maybe on top of that, you could also help me answer if the project seemed successful, then what are the plans for the scalability so that you can take it up in other places? The question for Wabuide is around culture and sensitivity. How did the research or the project, I can call it, address the cultural and social perception around disability and sexuality in the community? Thank you.
Okay, the last hand.
Or I can go first as I take to the next hand. Mine is just a simple question to the last presenter who talked about integrating entrepreneurship into SRHR. That's a strong aspect when it comes to prevention of teenage pregnancies and also women empowerment. But when we consider the community you are working in, that is Kalangala community, it's a moving community. Each time we have tried taking in interventions to do with women empowerment or entrepreneurship, you're going to train the group today, then the next day you're going to find half of the group has moved to the inland community. So it's not sustainable. So I just wanted to learn from you how your team is working hand in hand to make sure that it is either targeting the local natives of the area or how the entrepreneurship integration is being sustained in the Kalangala region. Thank you.
Thank you. Our last question.
Thank you very much. Mine is not a question, just a comment. First of all, to appreciate the great work that is going on. But I noticed, and maybe from my field, I noticed that mental health is very small across board, and we know that mental health issues in this country are skyrocketing. We had a few suicide incidences recently. So just a request that when you're implementing some of these activities, which really from the results clearly show that they are working, if we integrate mental health in some of these activities, I can give you for a fact in our area, I think about 90% of our GBV cases that we identify, we end up enrolling them into mental health services that we are conducting. Thank you.
Thank you so much for your questions, very valid. So to
Very intentional. It was very intentional because we had guidelines that guided us. We needed 70% of our participants female and 30% of our participants males in these safe space discussions. Next. The next question was there responses of stigma, lack of meals at school leading to HIV? Yes. Sorry, I couldn't share my action plan, but these were actual issues raised by the learners. They actually raised that there is stigma. They actually raised there is parental negligence, where parents do not provide, and they are left at the mercy of doing, of course, engaging in relationships at a very tender age. Then was there a response from the parents? Definitely, because these young people directly, it wasn't an attack, but sort of an opening eye that, okay, you know what? We as young people are facing challenges with parental negligence, thus leading to some of the early marriages and all that. And this clearly exposes them to a lot of SGBV, that is sexual gender-based violence, and HIV. The last, what did we build on, what information did we share, and what are our plans for sustainability? The information that we shared, we spoke about a lot of information on comprehensive sexual education, that was STI management. We spoke about HIV. We spoke about GBV with the learners. So this was basically age-appropriate information. Then what plans? I can reassure you that we are working closely with some of these local government officials, like our DHO. We have personally reached out to her to ensure that these safe spaces are actually put in schools, and with the help, of course, of the DEO. And yes, we are working closely. Of course, we do follow-ups once in a while, checking also on these schools and interacting with them. How far with the sex education talks at school do these learners actually have they incorporated this into their timetables? That it's clearly because they are not actually what privileged like these children from city schools and all. So thank you.
Thank you so much. The colleague who asked me about the migrant community, it is true that was the story before, that fisher folks keeps on moving in search for fish. But when you go to Kalangala now, Kalangala of 1980 is not the Kalangala of 2022. If I'm not deceiving you, the teams are here. When you go to Kalangala, there is infrastructure now. We have electricity. We have tamaka. We have started constructing houses of permanent structure, the bricks houses. So there was a lot that has been done about the mindset change. Now, when you talk of the movement, it's not all the population that are moving from one island to another searching for fish. No, those are just a few people. The fish are for about 10, 5, but not everybody that will keep on what? Moving. So they are there. Even if they move, they don't go. Now we have programs from yoga. You mean they run out with the government money because they are moving? No, they are there. Probably the speaker can add on. He has something to supplement. But
all right, thank you. I have 4 questions, and I'm going to follow the ascending order. Now, the first one was for Juma. The question was, he saw the, okay, we followed the standard definition of young people, and we used the WHO standard definition. That's why we started from 10 to 24 years. And when you look at the age variation between 41.7 and 33.7, That's something like 8 point something %, right? So there's no big variation there. And then the other question was on, we should quantify our data. Ideally, we did qualitative. That's why I was reporting the voices, not statistics. I hope the person who understands that was Okumu. Then the question of, did we involve politicians? Yes, we were very keen when we were selecting our key informants. We had LOC ones and representatives of young people with disability who were politicians among our key informants. Then there was a question about cultural norms. How did we factor in? In our study, men interviewed men, then women interviewed women. And the other thing was we recruited participants who could only speak the local language, not the English. That's how we sorted it. Thank you.
Thank you. Thank you so much. Can we give a hand of appreciation to our panelists? These were very beautiful presentations, and we hope our rapporteur for this session took the key issues that came through. So I want to thank you. You can take your seat, and thank you so much for listening.
Amazing. Thank you so much to the team HIV/SRHR. And of course, thank you so much to each and every one of you that has stayed with us up until where we are at now. We have arrived at the closing of our conference. We still encourage each and every one of you to follow the conversation on social media using the hashtag YouthConference2024 and I think Youth for SRHR. I'm not sure if I see people are still coming in as they walk in. I would also like to encourage each and every one of you to follow Power to Youth on social media as well, on Twitter, on Instagram, on X, on Instagram as well. And you'll be able to follow through some of the content that we are sharing out there in regards to our program and in terms of the change that we are creating in different communities. So as we bring this event to a close, we as a program pride ourselves in trying to also share as much as possible so that we can be able to learn from each other. And one of the ways that we do that is, of course, not only social media, but also dialogue in different communities, especially where we are based. The program is also bigger than it is. It's not just in Uganda. And, but I believe I shouldn't be the one to share more about Power to Youth and how we are working. And therefore, I would like to request Mabel. Mabel, if you're ready, I'd like to request that you slowly walk to the front. Mabel works for Gender Justice, and she is going to be giving the closing remarks for the ceremony. And they usually say when they close, no one else should speak, not so? So I would like to say a big thank you to each and every partner that contributed to the Power to Youth, the annual CSO Knowledge Sharing Conference on SRHR, Gender and Youth Programming. A big shout out to Reproductive Health Uganda, UWAF, IASI, Sonke Gender Justice, SRHR Alliance Uganda, Uganda Cares, Restless Development, Straight Talk Foundation, We Lead, Main Engage Uganda, and all the CBOs and CSOs that have represented, because it's not easy to travel miles, yeah, all the way to Kampala to attend a conference, right? But you're here because we believe in the change that you seek to create and to the conversations that you're bringing onto the discussion. So I will request okay, so I'll just let Mabel, who is already here, come in and close. And I remain Daisy Kandole. Sami had to catch the beat on NTV. He sends his apologies, but he's also super grateful for the time and such a good audience that you've been. Thank you so much, Mabel.
Thank you so much, Daisy. A good evening to everybody.
Good evening.
I'd like to, first of all, appreciate all of you for braving this long day. Okay, so an announcement here. Those who are in the panel just now, you've been requested to meet at the back. I think there's some organization that's happening for you at the back there. Another announcement, there's an assessment that is being given to only young people, right? To young people. I don't know who has it, but I think they'll come and find you. Who? David, okay. At the back over there, she's put her hand up. Thank you. I'm really going to be brief, and I tried to put down my notes so that I don't go on and on and on as we normally find ourselves doing, so please bear with me. My name is Mabel Nabagala. I work with an organization called Sonke, Gender Justice, and I know many of you have been hearing Sonke, 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 and you're probably wondering, what is this Sonke? So Sonke is a South African-based organization. We are registered in South Africa, but we work across Africa in 24 countries through our Men Engage Africa partners. You've also been hearing Men Engage Africa, Men Engage Africa. So Men Engage Africa is an alliance of organizations that work to promote gender equality and human rights with the key strategy of engaging men and boys. So when you hear Men Engage, it is because of that strategy of engaging men and boys. So as we close this inspiring annual knowledge sharing conference on SRHR, gender and youth, I would like to appreciate all the partners who have contributed to this event. The names have been mentioned. I don't want to repeat them again because of time, but I think the most important thing for us is what was the purpose of this event? What are we taking away as a group? What have we learned? What partnerships have we made in this space? And what are we taking, how are we moving on to those partnerships beyond this conference? And that's what's important. Because when you come and listen to case studies that we've had here in the GTS session, in the youth session, what are we picking from them? What can we replicate in our own programs? So I think that's what's the most important thing. We came here to listen to each other, share experiences, best practices. So what happens next? Let's try and either replicate, reach out to the person who was presenting that topic, see what you can take up from them, and then we can move this gender justice and human rights work forward. As Sonke Gender Justice, we are committed. We have been supporting the Power to Youth program as one of the consortium partners. And although the program will come to an end next year, we hope that we can find resources to continue this work. I've heard from some of the young people speaking here how amazing this program has been for them. How the program has built their, I think I had the lady here from Kalangala, right? How they built their capacity. And we don't want that work to stop here. How do we build on that work? But beyond looking at donors, even us within ourselves, how do we work together? How do we collaborate? How do we synergize resources? Because one of the biggest challenges of CSOs is all of us are trying to run with our own pocket. And when you do that, we lose out on the chance to bring the resources together and do big things. So I think this event was in the room. What are they doing? How do we partner with each other? And I hope that from here, we can find each other, begin to work collaboratively, and continue.
Some administrative remarks. We have a bite at the back, so please pick a snack as you move out. We don't want you to leave the food that was paid for the people at Africana, so please pick a bite. We also have a storybook for change on your table. There should be something called The Expedition. We encourage you to make sure you move with your copy so that you can familiarize yourself with the work that we're doing in the community and at national level. Thank you.
No, take a good pie, take a good sweet medication. He and be a she dagan. ondazo omukwano mungi wakuguga okusinga bangi nsomose emigga mingi nga noonya amazzi ne baseidi hakuna ni wandawa hakuna dawa otaliyo moyo gunuma hakuna dawa baby you're the only one dawa hakuna dawa dawa dawa
Onyete kubanjire